Welcome to the MarylandEMS Protocol Base Station Updates. First, I would like to thank you for taking a few minutes of your time to learn about our protocol updates for 2024. The hospital base station is a critical component of our EMS system, as it provides online medical consultation for our EMS clinicians. It's not always possible or practical to write a protocol to cover every situation. As a base station, you're providing guidance for EMS clinicians in these tough cases. Before we discuss this year's updates, I would like to take a moment to cover a few brief points. First, Maryland's EMS protocols are updated annually. The additions and changes for each year go live on July 1st. Second, this update focuses only on the additions and changes to the statewide treatment protocols. We have several optional, supplemental, and pilot protocols that jurisdictions may take on. The jurisdictions and their medical directors provide additional training, equipment, and ensure thorough review and medical oversight. We will not cover these during the current presentation. However, EMS agencies and base stations should stay in close communication so that they know if a given county is participating in any OSPs or pilots. Finally, the entire protocol document is available on the MIMS website. I've included the hyperlink at the bottom of this slide. Now, we will move on to the protocol updates for 2024. As you can see, there are several significant changes to the EMS protocols this year. I've grouped them into a BLS/ALS and ALS only column here. We'll take a look at each area briefly, one by one. BLS and ALS protocol changes. For burns, the Palmer method replaces the rule of nines for estimating body surface area, or BSA, burned. We have switched to this method based upon feedback that BSA estimation with the rule of nines leads to overestimation of the burned area and hence overzealous fluid resuscitation. The Palmer method is also easy to use. The patient's hand, including their fingers, is approximately 1% of their body surface area. Importantly, only second and third degree burns are included in the estimation. We have clarified the carbon monoxide poisoning, Protocol 7.1, and burn, Protocol 8.1 protocols this year to ensure that the patient reaches the most appropriate destination for their time-sensitive injury. Patients with suspected CO poisoning or isolated smoke inhalation without any suspected thermal airway or significant second or third degree burns should be triaged to a hyperbaric medicine center. Patients who have suspected thermal airway burns, on the other hand, with or without smoke inhalation or CO poisoning should be triaged to the closest appropriate burn center. Language line resource. Although this addition to the general patient care section is simple, we believe it will help improve patient assessment and communication. For patient encounters with a perceived language barrier present, EMS clinicians should use a translation line via their PSAP or 911 center or through another jurisdictionally approved method. For pediatrics, based upon lack of evidence for improved outcome, we have removed the requirement for BLS and ALS clinicians to administer supplemental oxygen to suspected pediatric stroke patients. Additionally, we've included pediatric resources and guidance on fluid boluses to the VAD protocol. There is now specific contact information for pediatric centers. There is also guidance on fluid boluses for pediatric VAD patients with hypoperfusion. ALS clinicians should administer 10 mL per kilogram of lactated Ringer's fluid boluses. This may be repeated once as needed for a MAP that remains less than 60 millimeters of mercury. As we strive to improve survival from out-of-hospital cardiac arrest, we have made several revisions to the adult VF-VT algorithm. For patients in VF or VT, we will start with the provision of high-performance CPR and prompt defibrillation. However, for patients who have persistent VF or VT after the second shock, we will prompt the clinician to consider transport to a hospital with eCPR capability if the patient is between 13 and 60 years of age, the arrest was witnessed and had CPR performed promptly, the initial arrest rhythm was shockable, and the transport time to a hospital with eCPR capability is 15 minutes or less. While there is not a formal designation process for eCPR-capable hospitals, we will inform clinicians of the hospitals that have the intervention available. At the current time, these include the Johns Hopkins Hospital, the University of Maryland Medical Center, and MedStar Washington Hospital Center. To recap, EMS clinicians will consider transport to a hospital with eCPR capability only if the patient meets all criteria. In addition, for patients in VF or VT, ALS clinicians will administer amiodarone 300 milligrams early, followed by a single dose of epinephrine 1 milligram IV or IO. For patients who have persistent VF or VT after the third shock, we will continue on to alternative defibrillation techniques and medications. For patients in VF or VT after 3 shocks, with one cardiac monitor defibrillator available, we will advise the clinician to perform vector change defibrillation. Stated simply, if the initial defib pads were placed in an anterolateral position, we will move them into an anterior-posterior configuration and attempt further shocks in CPR. All shocks will be delivered at the highest energy in joules permitted by the manufacturer. If the patient remains in VF or VT after the 5th shock overall, a single dose of esmolol, 500 micrograms per kilogram, will be given. Esmolol is a fast-onset, short-acting beta blocker that acts as a sympatholytic. We will continue resuscitation attempts until ROSC is obtained or a termination of resuscitation decision is made. For patients who remain in VF or VT after 3 shocks, when there are 2 cardiac monitor defibrillators available, we will advise clinicians to perform dual sequential defibrillation. With dual sequential defibrillation, there are 2 sets of defib pads connected to 2 different cardiac monitor defibrillators. The diagram at the bottom right-hand corner of this page illustrates pad placement. Notably, the same EMS clinician will deliver the 2 shocks using the same hand. There will be a short delay of 1 second between shocks. This is to guard against the delivery of simultaneous shocks. I want to emphasize the shocks will be sequential, one, then the other, and not simultaneous. Due to concerns with timing and pad placement, a monitor and AED combination will not be permitted for dual sequential defibrillation or DSED. Patients receiving DSED who remain in VF or VT after the 5th shock will receive a single dose of esmolol, 500 micrograms per kilogram, as mentioned previously. Now we will cover some of the protocol changes that apply only to ALS clinicians. For asthma and COPD, paramedics will no longer need to consult for repeat doses of albuterol when treating adult and pediatric patients with persistent or recurrent symptoms. EMTs and CRTs must still consult if the patient needs additional albuterol beyond the 2nd dose. Paramedics do not need to consult for magnesium for adults with moderate or severe exacerbations of asthma or COPD. However, the consult requirement has been preserved for CRTs and for pediatric patients with asthma exacerbation. Diltiazem. We have added a precaution for the use of diltiazem in patients with a history of congestive heart failure or decreased ejection fraction. Notably, hypotension may occur rapidly following diltiazem administration to these patients, and clinicians should be prepared to give calcium chloride. Droperidol. This protocol change allows for the use of droperidol for nausea and vomiting associated with migraines, cannabinoid hyperemesis syndrome, or cyclic vomiting syndrome. Protocol change also permits a single dose of droperidol for persistent nausea or vomiting after a dose of ondansetron. Pediatrics, needle decompression thoracostomy. We have clarified the appropriate needle size and location for needle decompression thoracostomy in children. For patients less than 4 years of age, EMS clinicians will use a standard-length 16-gauge IV catheter placed in the 2nd intercostal space at the midclavicular line. For patients 4 to 15 years of age, EMS clinicians will use a 14-gauge 3.25-inch needle catheter placed in the 2nd intercostal space at the midclavicular line. And finally, for patients that are 15 years of age or older, EMS clinicians will use a 14-gauge 3.25-inch needle catheter placed in the 5th intercostal space at the anterior axillary line. The 2nd intercostal space at the midclavicular line may be utilized as a backup site for these patients. Pediatrics, TXA. By way of review, the indications for TXA in the Maryland Medical Protocols are suspected hemorrhagic shock due to an injury that occurred within the past 1 hour, or postpartum hemorrhage with ongoing blood loss, with delivery having occurred within the past hour. This year we've added pediatric dosing for TXA. For patients who are less than 5 years of age, medical consultation is required. For patients that are 5 to 11 years of age, dosing for TXA will be 500 milligrams and 100 mLs of D5W, LR, or normal saline, given over 10 minutes. And finally, for patients who are 12 years of age or older, we will administer 1 gram of TXA and 100 mLs of D5W, lactated ringers, or normal saline, given over 10 minutes. In closing, I'm grateful for your continued support of Maryland's EMS system. Hospital base stations serve an essential role in the provision of online or real-time medical consultation for EMS clinicians. Thank you again for taking time to learn about our protocol updates for 2024.